Hey, good morning, everybody. Thanks so much for coming out. I'm Colin Rahm. I'm the head of health policy at Andreessen Horowitz. Just wanted to say thanks to CTA, Aaron and Catherine for hosting a great event and having a wonderful set of panelists here. So I'll kick it to my colleague, Munjal, for an introduction.
Good morning, everybody. I'm Munjal Shah, co-founder and CEO of Hippocratic AI. What our company does is we've built a large language model just focused on healthcare and use it to build agentic agents that focus on talking to patients within the scope of nursing primarily. And we're about a 2-year-old company, started in March of 2023, and are actually live now with about 23 health systems in the US.
Hi folks, I'm Neil Khosla. I'm the founder and CEO of Cure Health. We are an AI-enabled virtual primary care company.
Hello everyone, my name is Namwee Gong, founder and CEO of Figure 8. We're the creator of the first diagnostic companion for musculoskeletal injury recovery with scalability in mind. We already partner with thousands of physical therapy clinics across the country and collecting the first-in-class data that drives this AI-powered solution for personalized care.
Hi everyone, my name is Rashmi Joshi. I'm the founder and CEO of Asha AI. Asha is a voice-enabled conversational AI caregiver, and we help pharma to run drug trials virtually, making life-saving clinical research available to anyone from the comfort of their own home.
Great. Well, thank you guys so much. So over the last 2 years, there's been somewhere north of $43 billion of venture capital invested in health AI products and startups. Can you guys talk a little bit about why generative AI right now? Why is there so much excitement? Why is this different than other types of artificial intelligence? And what's really driving the interest in integration across health systems, plans, hospitals, and other folks across the healthcare?
You know, what I've seen is that generative AI has really allowed us to solve the staffing shortage that we see in healthcare. Right? We basically got AI that went from a 60 IQ to 120 IQ. We got AI that couldn't really talk before. You'd use an IVR and everybody would get frustrated, to an AI that's pretty fluent now. And then the most surprising factor is you now have AI that's quite empathetic, that is infinitely patient, that never judges patients. And so I think for the first time, and I think this is what's driving the excitement, we really, healthcare is still about care. And delivering care is still about expressing concern, expressing an emotion. You know, I'm so sorry, ma'am. And we finally have the technology that can allow us to deliver care, where I think before we thought we had that, we had an app, but apps aren't very persuasive. Apps don't convince you to take your medication. They might remind you, but you don't get credit till you take it. And I think we now have a persuasion ability that we just didn't have before.
Yeah, maybe the only thing I would add to what Munjal said is it is really jarring to compare how bad these systems were 5 years ago to now, even to some degree 4 years ago, even to some degree 2 years ago. So 2 years ago, ChatGPT launched in December, and many of you may have played with it in those early days. Something happened over the last 2 years that you didn't even realize, most likely, which is these systems can have multi-turn conversations naturally now. You ask a question to ChatGPT, it responds to you. You ask a new question, it responds back. And this was just rolled out very silently, and it works now, and everybody assumes it works. But 2 years ago, that wasn't a thing. So the rate of progress has been immense. And one of the things we see in healthcare versus other areas is there's basically zero tolerance for failure of these systems. And so we've gone from a world where, we started working on this 7 years ago, and there was basically sub 10% accuracy at some of these tasks, and now you see basically 100% accuracy in some of these tasks. We use these systems for things like translation as well, and we found people are stunned when we say, yeah, we've run these through large data sets of translation from medical conversations, and there's a 0% error rate. And people just are like, that's not possible. But it's what the data says. And so increasingly, I think it really is a product of how good the technology has gotten. And the biggest barrier right now is helping people who have been hearing about AI in healthcare for 5, 10, 20, 30 years in different cases understand how much of a sort of step function improvement we've had in the last 3 to 5 years.
Yeah, for us, I thank you for talking about persuasion, accuracy, but generative AI, if you think about healthcare, the reason why we trust really experienced providers is because they've seen a lot. Not only they've seen a lot, they know a lot. They know how this patient has gone through 3 different other specialists, and then here we are. How do we make the next step personalized decisions? So the generative AI really help us like look through a lot of different data sets and make sense of what it all means, and then tracking historically what this type of patient's the outcome and treatment is going to change the outcome, and then make a decision that is not like a normal algorithm that can do. You need to understand and then produce this personalized outcome. So that's why I think generative AI is just really going to change how we think about healthcare.
I'll add to that. So there's so many ways that Gen AI can actually bring us leaps and bounds forward from where we are even now. You can actually leverage things like digital twins to model out how a disease progresses and find new methodologies of treating it. I think it's just there's so many use cases to Gen AI that we haven't yet tapped into. For example, today, if you go to your PCP's office for your annual, they're expected to remember everything that they have learned throughout the course of their medical education at the drop of a hat, which is a huge ask for anyone, right? So what if I could actually take your experience as a 35-year in practice oncologist and download that to an AI? And what if I did that with 10,000 other physicians who've been practicing medicine for 20 to 40 years? Now I have an AI that's stronger than just one physician alone, but I can also look at different parts of the world, different geographical regions that have certain diseases that are more prevalent. And I think overall, in terms of the longevity and the future of Gen AI within healthcare, we're going to see AI being the primary modality for diagnostic decision-making long-term. We're not quite there yet. I think we'll touch a little bit later on why that is. There's a huge question around liability. Who do we point the finger at when things go south? I don't think we've figured that one out yet. But once we do, I think it makes a lot more sense to actually have an AI diagnosing patients than it does to have a patient being diagnosed by a human doctor. Human error is absolutely massive in any clinical practice. And unfortunately today, we don't have a good way of detecting when that happens unless a physician is getting sued by a patient, right? So there's this sort of general risk-averse fear on leveraging things like Gen AI in the clinical workplace setting, but we're not actually taking into account, if we're comparing from a probability standpoint, how often doctors mess up versus how often an AI messes up. I think we'll find that over time with critical data coming in, with data of mass, data at scale, that the AI is going to be much, much more accurate.
Absolutely. So the healthcare system today, 30% of all costs spent in healthcare is on administrative cost. 25%, give or take, is on waste, fraud, and abuse, which is almost $1 trillion a year in spend. Can you guys talk a little bit about, given sort of the bureaucracy in a lot of these big healthcare systems, can you guys talk a little bit about what are the hurdles or barriers and what are the ways that some of the big healthcare systems and hospitals are really reaching out to startups and innovators in this space to understand what technology is out there, how they can integrate quickly, and how they can create better process efficiencies to drive patient outcomes, but also to reduce cost?
Yeah, you know, when I first started this company, everybody said health systems move very slowly, payers are very slow, it's gonna take a long time to get things up and running. We've seen something quite the opposite. And I think it's just because their staffing pain is so high at the moment. Like after the pandemic, so many folks and clinicians left the workforce that there's such a gap that, you know, the health systems just signed up, you know, pretty much within a month or two. I mean, it was shocking. Now, it still took their legal department 3 months to get through the contract. But in terms of them making the decision, it was very fast. In terms of them doing the IT, it was very fast. Normally, if you sign a contract with these guys, you get put at the end of the line, and it's 12 months before the IT department will even start working with you. But we saw it much faster. But I think that, you know, you have to remember your average health system in America is teetering on bankruptcy. It's almost a zero margin business, or maybe it's 5% margin. There's a few like HCA that are very profitable, but most are not. Some are even running negative, and it's donations that basically keep them afloat. And so there is a strong incentive to try to at least quickly address and get money back out of the system and save additional dollars. So you're seeing just kind of right place, right time, where the technologies finally come, but the health systems in particular, but also now the payers increasingly, less so pharma, but definitely payers and health systems are just in a, you know, they're in a financial situation where they need to move fast in order to keep delivering the care that they want.
Yeah, I would definitely echo some of the same sentiments. I think the last 24 to 36 months, I think there's been a very big mindset shift. I think thinking back to the pandemic, where a lot of health systems, a lot of payers also started adopting virtual solutions at a very fast rate so that they could provide care in a world where people couldn't come into the office. That period lasted maybe 2 years, and so you got to the end of, say, 21, early 22, and people realized that it maybe hadn't solved the problems that they thought they were going to solve, especially with regards to the supply of physicians, supply of clinicians broadly, their staffing challenges. I think Munjal is right. And then also just how they operate their businesses. Most health systems in the US are actually just layers of cruft that have accumulated over 50, 60 years. And they tend to deal with labor that's very resistant to change, where they have technology systems that are very poor, if they have them at all. And so I think the last 2 years have been kind of like a cry for help, in terms of there's this new thing, we're not really totally sure what it is, but we're willing to be convinced if it can change the way that we operate. And so, I think I'm fairly optimistic too, as far as how fast this change is all going to come.
So we've all heard this story that in the United States, in the only place in the world where you walk into a hospital, you have a condition, and you will get a service that no one knows how much it's going to cost. And the reason why they can't tell you how much it's going to cost for certain procedures is because healthcare reimbursement insurance is as complex as healthcare itself. And when we talk about, having data about the condition, the experience in a provider, and how they can diagnose what's wrong with the patient, it's the same thing for people. That's the front desk staff, is the adjusters. They're trying to make sense of the roles and reimbursement. Where do you live? Why are you here? What's your copay? What's your annual deductibles? That's as complex as the problem itself. So AI really shine in those areas where there's a lot of complex systems that the human brain can't really possibly process them all really quickly. So I'm really hopeful that AI solutions, especially Gen AIs, can speed up those processes so that we have a better care delivery for everyone.
So we actually initially set up Asha not with the goal of entering the clinical trial space. So I founded Asha after my grandmother was diagnosed with cancer, and my family was grappling with how to manage her care from the opposite side of the world. And I wanted to build a tool that anyone, whether they're elderly or disabled, whether they're bedridden, can use, that's as easy as having a conversation with your loved one, that can help you stay compliant with your care and keep family members informed on what's happening with the health of their loved ones. So what's funny is in the last 6 months, the head of clinical innovation at Memorial Sloan Kettering approached me and said, Rashmi, do you understand what you've built? because we have been looking for a tool like this for the last 10 to 15 years. We've been looking for a tool that's going to help us to run drug trials virtually. And let me tell you why that's such an important thing. Today, if you have, let's say, a rare form of cancer, you have a stage 4 diagnosis, terminal, and you've found this study that shows a tremendous promise on the opposite side of the world in New York City at Memorial Sloan Kettering. Well, today you would actually physically have to go into the clinic in New York to be able to participate in that study. So think of someone who is already very sick, may not have the money to fly in and out of New York and afford the hotels, might be bedridden, might have other disabilities or comorbidities at play. You're really precluding the majority of the patient population from being able to participate in life-saving clinical research. And therefore, we're really only making drugs for a very small percentage of the patient population. So as we started doing diligence and chatting with pharma companies, chatting with trial sites, the response has been an immediate and very excited, hell yes. And I think we're finally starting to see that this antiquated system of health that we operate in is starting to change, not just because it had to during the course of the pandemic, but now because there is a suite of new technologies, new tools that make it so much easier for us to do the things that we're already doing. And eventually, I think we'll come to a place where we're actually decreasing the cost of healthcare overall because we're able to offboard a lot of these tasks that are done manually today by clinicians.
Great. So shifting topics a little bit here, the healthcare system in the United States is oftentimes a little bit of a comparison between the haves and the have-nots. Can you guys talk a little bit about the opportunity that AI brings in terms of health equity and access? Because I think one of the things, at least central to the thesis of a lot of the investments behind a lot of AI technology, is that this is going to lower the barrier of entry into the healthcare system and really allow for lower cost but more acute levels of care to be delivered to all patients, regardless of your income status or how rural the neighborhood or state that you live in is.
Yeah, so a very concrete example of that is one of our customers is WellSpan Health in Pennsylvania. And WellSpan had this problem of what's called a colorectal screening. They were trying to encourage folks to get a FIT kit, which is a fecal occult test to screen for colorectal cancer. Now, they had a certain rate that they had gotten their English-speaking population to, but they had not gotten their Spanish and the other non-English speaking populations to anywhere near that rate, because they would call with nurses, but they didn't have nurses that could speak. They actually literally didn't even have nurses that could speak Spanish, let alone other languages that are in their community, like Arabic and Hindi and other things. And so they actually called us up and said, hey, look, your LLM can speak every language, right? And we speak about 15 languages fluently today. And can you call them up and see if you can convince them to take the FIT kit and to do their colorectal screening? And can you at least get it to half the rate of the English-speaking population? So they gave us the folks that they wanted us to call. It was, I think quite a few people, thousands of people in there. We made the phone calls. By the end of it, we not only got the population, the non-English speaking, up to the level of the English, we actually got it 2.5 times higher. And they actually chatted for twice as long with the AI as the English speaking people did. So, and it cost the health system $1.50 a person in AI speaking costs to convince them to get a FIT kit, which is super cheap. Actually, it cost them almost $4.50 to do the same thing for the adult population with the English, because the Spanish and the other languages just took the FIT kit more. We're just so comfortable and excited that it could talk in their language. And this is what we see. Like, my mom has been in the US for 40 plus years, right? She speaks English just fine, but I've watched her when she sees an Indian doctor and she'll ask them, do you speak Hindi? And then if they do, she'll just talk and talk and talk about what's going on, not only in her life, but everything, but she'll also just share her pain and her issues at a much greater level of detail. And so I think a very simple, easy answer is to use LLMs to bridge the gap for all your non-English native populations. Even if they speak English, I suspect they're just more comfortable speaking their native language. And we can do that for every single population on every single procedure and every single screening outreach, period. And so I think there's, it's not just something we think is going to happen, it's happening today.
Yeah, I mean, I think we come at this from the angle of just access, which is if you want access to clinical services in this country, you're often waiting. I mean, the average wait to see a PCP in this country is 3 weeks. So if you want to see a primary care physician, you got to do it at the end of the month. I mean, I live in Palo Alto, or I live in San Francisco now, but, I have the best health insurance you probably can possibly have. I needed to see an allergist, and it took me over a month, right? And so one of the things that's amazing about these models is you can go online today, and with a system that's not particularly tuned or great for healthcare, you can still get a pretty reasonable answer. And as we've started working on systems that can provide access to clinical expertise or be a front line in front of the clinician that the clinician can review and finalize the care plan from. We're finding that you can dramatically speed up the time to get access to expertise, both in primary care, but then also in downstream specialty care, where you can take the PCP and give them the knowledge that a specialist would have. And so, we see this, for example, in our model with Tufts Medicine in Boston. In Boston, multiple of the largest systems will not take a new primary care physician at all. So Mass General Brigham, no new primary care patients anywhere in Boston. And so we worked with Tufts to say, hey, if you want to get a primary care visit through Tufts, you should just come to our system first, which is going to put you into an AI encounter and then in front of a physician who's going to make sure that the AI pointed you in the right direction before the care plan is finalized. And what we're finding is it blows patients' minds consistently to get the level of access and the speed of response from the healthcare system, but also from a little bit like what Munjal said, which is the amount they can talk to these systems. We have found consistently that the customer satisfaction ratings are higher talking to a AI than they are talking to a nurse or a mid-level. We have found that patients are willing to use these services like 100 times in 100 days when they're dealing with a chronic illness. And that's just not something that you see with the traditional healthcare system. So a lot of it comes to the things that people would pay for in concierge medicine now are available to the average American. And the question is how this gets rolled out and deployed at scale. So
I'm really curious and excited about the PCP being enhanced by AI. I do see a change of how we interact. Like when you interact with another human, disclose your concerns and worries and health conditions. I do think that there is a different relationship between you talking to an AI versus you talking to a person. The bias between you and the person really changes how you interact and disclose about your concerns. So I'm really excited to learn more. In terms of AI and equity, health equity, for me it's all about resource allocation. In our field, we talk about musculoskeletal health. It's either preventive or conservative treatment with physical therapy, or you have a surgery. So who gets a surgery and who deserves a surgery, and who makes the decision for the specialist? Do you go to an orthopedic surgeon or do you go to physical therapy? It's mostly made by PCPs. Primary care doctor will say, okay, you experience a lot of pain. You cannot function as a person. Here is painkiller and more painkillers. That's the standard. But if we have more data and more information, through these generative AI system, we can make decisions on who actually need the care and appropriate those resources. And instead of only people who lives in, say, New York City, Boston, San Francisco gets a surgery and everyone else just gets painkillers. Yeah.
So on the topic of accessibility, that's actually specifically why I built Asha. I was blown away to find out after we took all of our time trying to find any resources, any tools, any services that would help my grandmother and our family through her cancer diagnosis, that none of it actually made sense for elderly people to use. We went through probably 3 or 4 smartphones, tablets, different apps, and she couldn't figure out how to use it and frankly didn't have an interest in learning. And so I was sitting there scratching my head thinking, how is it possible that we're living in a society where the patient population that requires the most amount of care are elders, who typically have, 3 to 5 conditions they're managing at a time? How are we not making tech tools in healthcare accessible to them? So that's actually why I built Asha. I was watching my grandparents interacting with Alexa, with their Echo device, and they thought it was the most amazing thing in the world that they could ask her to tell them jokes, play their favorite music. And I thought, how interesting would it be to have a tool that they can just chat with, that doesn't require them to learn a new skill or a new piece of tech, and have essentially that gap bridge between me or my mother being there with them physically, helping them remember which medications to take when, helping answer any questions that they might have, and making sure, most importantly, that if they require care, that we get that for them in real time. And so I think it's come leaps and bounds since then, because as you mentioned, there's so many places in the world that lack access to even hospitals. Some people might be driving 2-3 hours before they're able to actually see a physician or get an x-ray. And so this new suite of technologies, including Asha, can help bridge that gap and really bring health home. 90% of health doesn't happen in the hospital. When you're going to the hospital and you're sharing, hey, here are the top 3 to 5 things that are bothering me over the last year, you might be missing 15 or 20 other things that you don't have the time to ask that physician that could be hugely impactful to your long-term health. So being able to not just identify these, but prevent decline by small things. Like, let's say, I regularly crave ramen. I know it's not good for me. For someone who's on a low sodium diet, being able to say, hey, guess what? Here's a meal recommendation that can scratch that itch, but still falls within your medical diet. Doing small things like that are hugely, hugely impactful to long-term health. And so having a tool like Asha that's kind of your companion, that is not just something you use every day, but becomes something you look forward to engaging every day, that helps you stay on top of care and make sure that you're feeling less lonely, I think is such a tremendous value. And watching people play with it has been my greatest joy as a founder.
Great. So shifting topics, or actually really along the same lines, there's been a lot of conversation around bias, around personalization, there's a debate whether one person's bias is another person's personalization. Can you guys talk a little bit about what are some of the best practices that you deploy as developers, whether it's looking at the training data that you're using to develop your tools? What are the steps that you all take to ensure that patients are getting access and your tools are working effectively for the patient population they're built for?
Yeah, this is such a loaded thing where everybody says, oh, let's talk about bias of the model. And
I wanted to put everyone on this.
Yeah, thank you for that. I really appreciate it. But the real question is, can we please define what kind of bias? Are we talking about racial bias? Are we talking about gender bias? Are we talking about income bias? Second, what is the standard? Does it have to be perfect? It's never biased ever? Does it have to be less biased than 90% of clinicians? Does it have to be less biased than 50% of clinicians? What's the acceptable standard? So the biggest challenge is nobody's answered those questions in any satisfactory manner. They're like, well, I don't know, it's got to be perfect. We're like, well, humans aren't perfect. They're pretty biased. In fact, they're incredibly biased. But, does that mean that you're going to not have this care go out because it's at 98% and not at 100? So I think there's some real important questions to be asked there that honestly are unresolved. But that being said, I don't think, there's a flaw in everybody's thinking on language models. If you know what it's trained on, you know what comes out. That is so not true. How many of you have actually used PubMed GPT? It's only trained on PubMed, it's only evidence-based content, and it makes stuff up all the time. And so there's this assumption that garbage in equals garbage out, but it turns out good stuff in can still equal garbage out. And so we do bias testing on the output, not on the input. We literally have we hired 5,400 US licensed nurses. They've made 260,000 test calls. At the end of all of those, we said, do you think this AI is more biased on these dimensions, gender bias, this bias, that bias, than your average colleague? And what did you think? And so we literally measured all those. We use that as our benchmark. When we find issues where they do say it was biased, we go back and look at what the AI said. We go back and try to fix those cases. And we've been doing that for 18 months continuously, but we do massive output testing on it. But I will still tell you, we still don't know where to set the threshold. There's still a question of like, is it gotta be perfect, or it's gotta be better than the average, or better than 90%? My hunch is the right answer is probably something like better than 80% or 90% of human clinicians. Like, I think that's probably the right acceptable range, but time will tell. But right now, we don't take that approach. We just try to get rid of every issue we find. But there's a lot of different ways to test and see bias.
Yeah, I'll just I'll add on to that and say I think Colin kind of mentioned the piece about bias and personalization. Those are two sides of the same coin for us. If you have a patient who is in Greenwich versus a patient who is in the Bronx, they're going to have different needs. And so the AI should be personalizing to the needs of the patient. Now, you can also call this bias. And so what do we do about that? And so that kind of becomes a values question as well. And of course, one of the challenges as an AI developer is nobody gives a shit. Nobody gives a hoot. But you're going to be critiqued either way, and so the best we can do, as Munjal was saying, was measuring, and so trying to create transparency is an advantage that humans will never have. There's very little transparency or insight into where they are biased and why they're biased. But with an AI system, you can actually measure it and say, hey, these are the areas where we're paying attention to social determinants versus not. These are the areas where this shows differences in one patient population versus not, and why, and is this appropriate, and to have that conversation. I don't think you're necessarily going to solve these issues, which tend to be values-based, with a set of metrics. I think you're more likely to solve them with continued thoughtfulness, monitoring, and discussion.
I think there are two different types of bias from my perspective. One is the bias that's access to care, right? This bias from people to people. And another is there are fields of medicine, like what Figure 8 is working on, is musculoskeletal health, where the clinician aren't even given the tool today to have quantifiable measures. That's the input. And an outcome measure that is digital, scientific, and that is not based on human subjectivities. So not just in our field in musculoskeletal care, but the example of how a clinician measures the performance and get care today is to ask, how do you feel today? Like from scale of 0 to 5. You will see like the smiley face, the sad face. That's the patient reported outcome. I call it signs by emoji. And then there is the bias of the clinician says, well, patient exhibited weakness on the right arm. There is a limited motion. And these are highly subjective, and that's why the cost of healthcare is so high, because when you are measured by those input measurement on the condition and the outcome measurement on how you have recovered, when a clinician tells you that you have healed, it really means very little, because how do you measure the outcome of those care? So our mission really is to create the data set that is meaningful, digital, repeatable, that can deployed across the board, so that any AI outcome treatment suggestions can be meaningful. So I think that's one layer below most of the Gen AI healthcare products. It's just like creating a meaningful data set first for outcome measurement.
So two things that we do is we have a very diverse group of builders who are actually building our models. And I think that's really important because they're able to think about things in different ways. So whoever is building your AI, I think having a diverse group of, they don't have to be coders, right? But those folks who are putting their heads together and thinking about, from a product standpoint, what are the questions that patients are going to ask? And being able to come up with different use cases that, different people from different parts of the world with different socioeconomic backgrounds, different racial backgrounds, different ages, genders, having a diverse group of people who are conceiving those and making sure that the AI is treating those questions appropriately, I think is hugely important. And the other thing I would stress is focus grouping. So not just getting training data, but also being able to do focus groups around how your AI is being used and having a diverse set of users who are in the room helping ask all the questions that your product folks didn't come up with. And making sure that you're continuously getting feedback and leveraging that feedback to make your model stronger, smarter, more resilient, and ultimately less biased, I think is very important.
Great. So we only have a couple minutes left. A number of you touched on this throughout the conversation, but what are you all looking at as developers and entrepreneurs in the AI space as DC regulators, lawmakers have been thinking about how to regulate this? I think there's the issue around liability, some of these issues around sort of arbitrary numbers around bias alleviation that I think folks have been trying to put into place, not really recognizing how the technology works. So can you guys talk a little bit about quickly, what are the couple things you're watching over the next couple of years when it comes to regulation?
I think with this recent changeover in the administration, it's actually going to be positive. I think that the conversations that I've seen and had already with some of those is they're understanding really the big picture instead of getting lost in just the risks. And so to me, the big picture of generative AI is, we have a massive aging population. We don't have enough clinicians. We have to find some way to serve all these people's healthcare needs, not just us. The Europeans have the same issue. It's the same issue in Japan. It's the same issue everywhere. And we have one of two choices, but really the best answer is to embrace technology to help us. And we call this kind of a modality of abundance. All of healthcare has been locked in this framework of scarcity, probably for all of healthcare's history. The word triage assumes scarcity. Care pathways are scarcity. If you think about all of the population health, it always does risk stratification, which is I'm going to serve those who need it most. But actually what you're really saying is I'm not going to serve those who almost need it most. But I think we're coming to an age of healthcare, and I feel like the new administration actually understands this very well, where we can use technology to serve everybody. And I think this is the big idea I would share with everybody here, which is there's an age of abundance coming that we've never seen before. And we can actually redesign and need to redesign all of how we deliver care. And that's the power, and I feel like they get it.
Yeah. Oh. Hello? Oh. Yeah, I would say, I would ask the question, what is the cost of not adopting these technologies very similarly? And I think that if you look at the trajectory the US in particular is on, but it's true, like Munjal said, of the NHS, of Canada, of Japan, of even parts of the developing world, we have to lean into these technologies. Unless we want to spend, 50, 60% of our GDP on healthcare, we need to. And I think, the thing that I always feel is we have to remember that for the most part, the dollars come from the poorest and sickest and oldest Americans. And that, as a proportion of what they spend, I think is a big ethical quandary. When we have a system that is meant to serve them, but in many ways takes their ability to live. I mean, everybody's heard the numbers about, the average American not being able to, pay for a $400 surprise medical bill or things like that. And historically, our answer has been to try and regulate out these things. But the problem is the system will always find ways to serve itself, because these businesses are also pressured in a lot of ways. And so the question becomes, how can we adopt these technologies in a way, and how can we work with regulators not to alleviate the downsides, but to figure out how to solve the big societal problems that are starting to really eat at this country and every country globally.
We hear that clinicians, our partners, fear of AI. Patients are afraid of AI. And the real question is, why are we fear something? It's because there's the unknown. We don't understand something, we fear it. The regulator wants to regulate it. And the biggest challenge really is, how can we find common ground, which from my perspective is just outcome measurement. If we don't, there is the black box of AI that generates output, sometimes garbage, sometimes not garbage, sometimes 100%. But if we agree that we want to regulate that products don't meet certain standard, then they shouldn't be on it in the market, which is what the FDA does, then we are all in agreement, because we do want to serve our patients, we do want to provide better healthcare. So for me, really, it's about how do we agree on the right outcome measurements, and how can the technologists, like everyone in this room, work with the regulator on that common standard, as opposed to fearing each other. Like, we were afraid of the FDA, and then we were really surprised when they really just want to help us to develop better technologies. So it's finding that common ground.
Great. And sorry to have to cut it short, but thanks so much, everyone. Really appreciate it.